When we hear the word evidence, we tend to look at it as like the legal evidence for the crime. They look for evidence in the crime scene. Makes sense? But evidence found its way into the healthcare system, same like it does in the legal system. We in the healthcare field, we want to substantiate our decisions, our reasons why we chose that diagnosis versus another diagnosis with evidence. And evidence-based is kind of the ubiquitous term now in healthcare system, evidence-based nursing, evidence-based medicine. So this concept will be explored this week. If you look at your module, you had a ticket to class this week, and that ticket to class was to bring in an evidence-based article, whether it's a qualitative or quantitative research, but it had to be evidence-based. So we will explore that more in the classroom. More things we're going to explore are those terminologies that go hand in hand with evidence-based practice. What is evidence-based research? Why do we care about it? How does evidence improve client outcomes? What level of evidence we take? Are all evidence the same level as is the research in the literature the same, or do different research methods vary in their evidence substantiating the validity of what happened in that research. We're going to talk about the PICOT question and talk about the relationship between how that evidence base is going to improve performance. What do they do when they say quality improvement research? And what is nursing and research? Can you see nursing and nurses in the realm of research and in literature? And do nurses use that research and evidence base in their decision making, in their clinical judgment? We'll explore all this week. So taking evidence from how it is described in the legal system to establish whether there is a guilt or innocence, here we're not establishing that. We're establishing, is it beneficial or harmful? Is it going to improve or not improve outcomes? It is going to confirm a diagnosis or a conclusion, or it's going to disprove that conclusion. When used as a verb, evidence means to prove, and and that is the most definition that really apply to healthcare, and that's the fundamental. We want to prove that we can improve the healthcare delivery and the outcomes for our patients. Here are a couple of definitions of the concept and as it applies to evidence-based nursing. And what we need to understand here is that we use evidence-based practice to guide our practice. And it's an evolving, ongoing mission for the sake of a betterment of the healthcare delivery, for improvement of patient outcomes, and also to improve our skills and to be using the latest scientific evidence-based um, skills, whether they're soft skills or tangible skills that we are doing implementing, such as inserting a Foley, or are we talking therapeutic? Is that a therapeutic communication or not? We are gonna indulge more in evidence and talk about data when we are in class. So this collaborative learning we're gonna do in class. So how does evidence play? There is a scope how evidence goes, and it's kind of a cycle of life. So first you're discovering, you're in the lab, you're on your desk trying to figure out, can that be worked out, and then you make the evidence, you do the research, such as the research articles you read, and then you try to translate that research. They say that it takes 10 years for the research to go from the publication into practice at the bedside, and really it's anywhere between 7 and 12 years, and so the average is 10 years, because by the time you discover it till you do it at the bedside, you need to prove it. Same like when you talk about vaccine, that's almost the same connotation. So figure 47.1 in your book shows that. So that translational research is the moving of the evidence of research into the clinical setting, into clinical practice. It's called application of evidence. So what are some attributes of evidence? Replicability, reliability, validity. What does each term mean? And when they talk about attribute of evidence in box 47.1, you have those major attributes and minor attributes. So the major are replicability, reliability, validity, and the minor are publicly available, understandable, usable. So replicability is the, if you did it, if you did that research in your hospital, I should be able to reproduce that same outcome if I apply those same recipes you use in your evidence in my setting. So you tell me this is how you make a cupcake, and you say you follow steps 1, 2, 3, 4, and step 1, this is how long you spend, step 2, this is how long, and etc. And then it should be that if I follow your exact recipe, I should be able to replicate the same cupcake with the same taste, same outcome, same color if I use same ingredients. That's what replicability say. Reliability means is, if I use these, will I come to the same outcomes on uh, different patients? So if I apply the same treatment to patients who have the same disease over time, I should get almost exact outcomes. Versus validity, and here in evidence, we always want the evidence to be valid. We have to say that what we were measuring, we got to measure. So if we're testing the intelligence of a person and we use the IQ, we should come out with how intelligent that person. We shouldn't come out with how handsome that person is. So that's the accuracy in the gives that valid measure for the test. When they talk about the other attributes, the minor attributes, is like, what's the use of that evidence? Are we going to be able to use it? Are people going to be able to understand it? Is it going to be available for everyone? And that is really not major attributes, but they're very critical attributes. So what's the use of you bringing in an evidence that the general public can't use? So when the computers were made, they were made more than 70 years ago, and but when did become available for public? That would be like, why we care about those attributes of evidence. When we talk about levels of evidence, and we're not here talking politics, we're talking science. Um, so we're not talking about people getting on the TV and passing their agenda. We're talking about researchers who do good research, but is their research of equal quality? It is not going to be of the same quality because the criteria they used would be different. And so there was that grade um, um, way of grading the quality. So grading of recommendations, assessment, development, and evaluation attempted to see the measure of that quality of research. So it classifies the studies based whether they're strong or weak based on what methods was used. Was the sample size big enough? Did they do it on 10 patients or did they do it on 100,000 patients? Were the researcher and the patient blinded for the intervention and for the results? So there is no bias, so there is no Hawthorne effect. They say Hawthorne effect is like a person feels they're better just because you're giving them a placebo, and placebo is a fake medication. Like there is nothing in it. It may be just harder, but the patient thinks that they're getting the medication. So that's how that works. And then you have the other level of grading where they grade them according to A. If that is a very strong evidence, it's given an A. That means that um, institution recommends strongly to use. B means just recommends, and so on and so forth. You have that in box 47.2 in your book. But let's talk about internet. Is internet a valid sorry, a valid evidence? So we have easy access to internet. Are we gonna be using it? Yeah, if the information is out there with the methodology that was used, with the results that have been, and sometimes they'll ask the author to provide the data even, so that if somebody wants to check the level, they can have access. Of course, the data would be devoid of any information, so it's um, HIPAA compliant. So these are some of the places. You have places that are governmental where you can find evidence on the internet. And yes, Google can be a good buddy. Nurses have always been in the realm of research, and they've always wanted to be in research. We'll talk about this in a minute. So we'll do this when we are in the classroom. Want to go to this website and see what we can see there. And Nightingale became famous because she used, she documented her findings, and with that, she was able to reduce infection control practices in the Crimean War. Semmelweis was more forerunner of infection control. This guy, he found that women after delivery they're having postpartum fever. So he traced back and found that the residents that were delivering were the night before working in the morgue and in the dissection in their anatomy class, and so they carried some of that with them to the women, and so he imposed and made it really that kind of um, um, controlled study where in one clinic where he made it where they had to soak their hand and disinfect their hand, in the other where they were not, and then compared the results and found that the infection rate in the woman after delivery reduced and dropped in the clinic where they mandated the hand washing. And so it's been a journey in evidence, and we're not the first people to develop um, evidence base in healthcare. And then we have nice repositories that really save and host evidence. Like the Cochrane will only host those randomized controlled trials. We have also the guideline clearinghouse that is how evidence has improved over the years, from just being timid and simple approaches to hosting very valuable researches in open access websites. When we talk about types of evidence, yes, there is going to be two types, either through primary literature or secondary literature. So what does that mean? Primary literature means what I asked you to bring to class, the original research. You looked and found that this author did this intervention and found out after they did this intervention that the falls on their unit dropped by 50%. What is that? That's an original research. What is it, quantitative or qualitative? It's quantitative. What is then qualitative? Qualitative is that if you ask the nurses or about what's their opinion about that new manager, and then they say, oh, or they ask them about their experience with the care of terminally ill patients, and they say their opinion. So you write down what they said, and then you go in and collect that data and try to find a theme. Like all nurses, in the 10 nurses that we talked to seem to show signs of depression after they take care for a long time for terminally ill patients. So that's qualitative. It's not numbers, yes or no, 50% or 90%. And the mixed design is they use both. In the same study, they'll ask you, do you like Dr. Sharara's class? And the answer is yes or no. That's quantitative. Yes is a 1, no is a 0. Then they'll tell you, if you say no, say why. And or if you say yes, say why. That will be qualitative because you're going to put your opinion. So that's a mixed design research. What they talk about secondary literature is, for example, Sarah comes and says, I'm going to look for every article, research, original research article in the literature that talks about uh, using socks, non-skid socks for prevention of falls. So she goes and finds 10 articles where they did original research, and then she collects the data. Now you have all these data. Instead of having 100 patients in those 10 other authors, now you have 1,000 patients in your research, and you extrapolate data from the original research and you bring new knowledge. It has to be new knowledge for it to be evidence-based. So you say, oh, based on the fact that this was used in 10 different places, this is valuable. This is a reliable method, for example. And these are called systematic reviews, meta-analysis reviews, and the guidelines. Those, like I told you in the clearinghouse guidelines, these are all based on secondary literature. So they take primary literature that was scientific and collect them together to get you the secondary literature. We're going to talk about research and different parts of research when we're in class. That's going to be your activity. When they talk about bias, what do they mean about bias? So bias is when I am so eager about this research that I am initiating. Okay, I'm trying active learning for the first time in 117 because I believe in it, and so I tend to be biased that it's going to be successful. If I don't have biases, I'm going to see it objectively. So that's kind of the term when it talks about bias. So to reduce bias, what do you do? To reduce the bias of the patient liking this drug because they like how it feels, but you don't want them to tell you how it feels. You want to see the outcome that it improves their overall well-being. So what do you do to reduce the bias in research? We'll talk about this. Um, Research and research nurses as researchers. Um, like we said, we're on a search for that evidence. We're on a discovery journey. So how do you do that? you have to use the scientific method. Nurses can be the principal investigator in a study. They can be co-investigator. That means two people working together, or they can collaborate. For example, you're implementing the intervention. You are the direct person who's doing the intervention, or you're doing the data collection, or you're doing the data analysis. So there's many roles in research, and all everybody that participate in research is gonna be uh, eh, let me step back and tell you, if you had a part in the research, substantial part in the research, your name should show on that research. For example, if I did the literature review to prove that nobody before me did any investigation around the impact of active learning on first year students, so that literature search takes a ton of time. I should be included when they publish that article, even if I'm not the one who implemented active learning strategies, and even if I did not collect the data from the students, whether they liked it or not, and even if I did not run that statistical analysis of those information. Sometimes I may be doing all these, but many times this research takes a long time. So I will collaborate, and people collaborate with other people, either as investigator as or collaborator. So collaborator would be the person who, for example, does just analysis, or just does the not analysis, the statistical analysis, not the analysis of data and the meaningfulness of it and the discussion and the conclusion, but they just did the literature review or whatnot. And then in research, mostly when it comes to nursing, although there are scientists, nurses do tend to be more on the quality improvement research side. So they apply that plan, do study, act, and then so they say, okay, we're going to implement this because it reduces falls. That's quality improvement project. But you'll see a ton of projects around that in nurses, in nursing researchers. What are we too, other than researchers? We are consumer of evidence. Definitely. We are the people who use the evidence and put it in policies and procedures. Our Foley insertion is based on evidence. Our ventilator associated pneumonia bundle is based on evidence. Our procedures, how do we insert the Foley, is based on evidence. So nurses, when employed, you are going to serve on committees, and you are going to be having to bring the evidence into on to the table so that it will be incorporated in policies and procedures. Um, so in this part, sometimes you do not do the research. Sometimes you're not part of a quality improvement. Sometimes you're not in policy and procedure. You're just looking for the answer. You want to see whether what's been done is the best way to be done. What's being done is the best way to be done. So what do? You can go and develop the question. We're going to work on the search literature for it, and look for the evidence. What type of evidence is that? And then when you apply the evidence, you will find results and you evaluate the evidence. So not always you're gonna be doing research. Sometimes you're applying all these without even being in a research endeavor. For like, you're not publishing that intervention. You're just doing it for the goodness of it. So what do we do when we do literature search? Tessa did a great job around that. What I want to highlight for you is that is using Google and Wikipedia reliable source. Why we don't want to use them? Just because there are people out there that are um, publishing fake information, or they're not putting their biases aside when they are evaluating their information. So only when we use those search engines through um, the valuable and reliable resources that we can um, say that our literature search was reliable. And Tessa spoke about using keywords and phrases, and showed you that you can refer to that lecture and in the uh, YouTube channel. Okay, if you're looking in the internet, can I use something in the internet? Yes, you can, because many of the public open sources, they're on the internet. CDC is in the internet. The government websites is in the internet. That clearinghouse is in the internet. So just look for the domain. Does it say .gov, .org, .edu? Does it look like it is advertisement? Look for currency, relevance, authority, accuracy, purpose, that crap. And so there are checklists that can help you evaluate information online. But we don't want you looking in the internet. But later on, when you graduate and be nurses, you're going to be looking for that. So we'll try to build in you that sense of finding the evidence and knowing what is evidence based on what's not. Hopefully, we can achieve that. So what all concepts relate to evidence? These are some, and we will discuss them, and I need you to talk to me about it. How does evidence affect safety? How does it affect policies? How does it affect use of technology? How did it affect the economics in healthcare? And uh, okay, before we end, and I'm going to talk about all these types of trials and go back and tell you the evidence, how do we measure it. I want you to go into your book in page 453. There is a case study for an RN called Maika Kimura, and I want you to read it and come prepared with the answers to those questions, and we'll go over them in the classroom. So when we talk about evidence, we need to discuss the level of evidence. Okay, so what is um, the level of evidence? What research study is of higher evidence base? You have in figure 47.2 an evidence pyramid. What does that mean? That evidence pyramid talks that on top of the pyramid sits systemic reviews and meta-analysis. Then under it, you have the randomized controlled double-blinded studies. Then you have under the cohort study, then the case control, then the case series, then the case reports, then editorials and opinions, then animal research, then in vitro research. So that's how they're put in hierarchy. How come systemic reviews are above randomized controlled trials? Well, randomized controlled trials is as good as a scientific experiential trial or research can go. But we're telling you that the systematic review and a meta-analysis is above. I want you to think about it. In the classroom, I will tell you why, but I want you to think about this. When they talk about longitudinal studies, they're talking about studies that go over time. That also gives it so much meaningfulness when you talk about long-term study that happened over a longer period. Then your deductions are not the impact of now and here. It is really very long-term um, value, and that makes sense. Ethnographic studies are qualitative studies, but they use research methodology. In here, you look more about the anthropologists look into the culture and look at how the healthcare and the culture is impacting the outcome, the interaction between these students. More often than not, it's also a longitudinal study. They'll study the group over a long time. They're more observing of the group than a short-term intervention would be. Practice guidelines, like I told you, these are when experts sit and they put the the best evidence base, and they say, okay, this is what we're gonna incorporate in the practice, so best practice, and they put them in guidelines. This is what you do for a patient that comes with back pain. This is what you do for a patient that comes with knee pain. An expert opinion is not of any less value because you're really tapping into the mind. If you put five experts in a room, you have a think tank that is so powerful, and the book chapters, for example, these are kind of expert opinion because they're bringing other information from other people, but they're putting also their values into that. Guidelines, more often than not, they're expert opinions. And review articles. So the difference I want to highlight for you, the review articles versus the systematic review. Want you to, if you've listened here, you would be able to answer me that in the classroom.